abortion, or with this kind of scheme, or all of the above.
Okay, thank you, Dr. Jafar, for this informative lecture. Our next speaker is Dr. Imtiaz, ENT specialist. He will talk about dysphagia.
Bismillahirrahmanirrahim. Today our discussion topic is the dysphagia. Dysphagia is defined as difficulty in swallowing. This is a common presentation in ENT patients, young and also all ages, can with difficulty in swallowing. There is also a term odynophagia, which is a painful swallowing. It is important to know if it is a painful swallowing, it is mostly inflammatory or any corrosive lesions. For this, we have to diagnose this. We have to see what is this swallowing. Swallowing is a mechanism in which when we take the food, it is masticated or chewed in the oral cavity. Then it is mixed with saliva, and with the help of the tongue, it is made a food bolus, which is pushed by the movement of the food into the oropharynx. At this stage, the soft palate closes the nasopharynx so that this food does not go into the nasal passages, and the epiglottis blocks the laryngeal or airway pathway so that the food does not go into the airway pathway, and then food passes into a food passage which is known as esophagus. This esophagus is a food passage which connects the pharynx with the stomach. So any problem, infection, any obstruction in this all pathway can cause the dysphagia. Yes. Previously. Yeah. So for the clinical purpose, we can divide this dysphagia into the pre-esophageal causes and the esophageal causes. It is clinical important because all pre-esophageal can be easily examined in our ENT setup. We can examine and we can diagnose and easily treat them. For esophageal, we need some other investigations to rule out what are the causes. In the esophagus, causes may be in the lumen, in the wall, or outside the wall. In the pre-esophageal causes, the causes may be in the oral cavity with the chewing problems. If there is any problem in the mandible, like fracture or mandible, temporomandibular joint, or the mandible growths, they can cause this. Or there is lubrication problem, saliva is not producing. For example, after radiotherapy, there is a xerodermia and no saliva is produced. And this movement of the tongue, if there is abnormality due to the ulcers of the tongue, or the growth of the tongue, or the paralysis of the tongue due to some cerebrovascular accidents, or there is this problem in the palate. So there is a cleft palate, and then it is a problem in the swallowing, or the soft palate is paralyzed due to some bulbar or pseudobulbar pulses. In the pharynx, commonly we have the inflammatory causes, which is tonsillitis, the peritonsillitis, sometimes the peritonsillar abscesses, retropharyngeal abscesses, parapharyngeal abscesses, or any growth. So inflammatory and all the obstructive like trauma or the tumors, others, there is spasmodic spasm of that pharynx due to this tetanus or the rabies, or there is paralysis due to the diphtheria. In esophageal phase, the causes in the lumen are the foreign body, or it may be a tumor stricture. In the wall, there is a motility disorders, which can be diagnosed through manometric. And outside, there is something which pressing from outside on these passages, like goiter, thyroid swelling, cervical lymph nodes, inflammatory or neoplastic, or there is mediastinal mass, and sometimes when this stomach slides up and the paraesophageal hiatus hernia, this can push on it. So for this diagnosis, we have to take a history. It is clinically diagnosed by taking a good history. It is we have to rule out that it is progressive or sudden onset. Sudden onset, there may be a from foreign body, or there may be a there may be any corrosive ingestion, which may be accidentally in this in the laboratory work, or very rarely suicidal. Some people attempts this, and this if it is can be progressive is most probably it shows that the malignancy is the underlying cause. It may be intermittent, or it is intermittent. If it is intermittent, it is mostly this diagnosis is spasm of the passages, spasmodic. If it is more for the liquids, it is mostly for the liquids. It shows that it is a paralytic conditions. If it is more for solids, it shows that it is for the malignancy. So after we have to examine it, we have to thoroughly examine the oral cavity to see oropharynx, and also to see the esophagus, we have to do the esophagoscopy. Some laboratory work we have to do to complete blood picture, iron binding capacity, to rule out the Plummer-Vinson syndrome. There is in which there is iron is deficiency, and it causes the atrophy or aplasia of this skin, and it causes initially the dysphagia, and later on it can cause the strictures. In the other, we have to do the next. Radiology, we can do an X-ray chest to rule out any mediastinal or pulmonary cause, or any cerebrovascular cause for this dysphagia. Soft tissue lateral view, it can show this something parapharyngeal masses or abscesses are pushing from the outside. And barium swallow, it can be in which is a barium solution is given, and patients are to swallow, and then X-rays are due. It will show the rule out where is the exact site of the stricture or malignancy, or sometimes there is a diverticula, thus other passages which can be diagnosed. And in this, if we have the flexible endoscopy, this is a tube which passed, and directly we examine the oropharynx, and also after this the esophagus. Mostly it is done by the gastro people. In ENT setup, we have rigid endoscopy through which we examine if it is both diagnostic and therapeutic. Diagnostic, we have to see where is the lesion. If we find some lesion, we take the biopsy from that and send for histopathology. And sometimes if there is some foreign body, we can remove that foreign body. So dysphagia is not a disease, it is a just symptom. We have to diagnose it by taking the complete history and examination, and if needed some investigations. Very rarely if there is this paralytic causes, we have to do the monometric studies of this esophageal passages. So treatment, it is very simple. It is according to the cause. If some cause is we can diagnose, we have to treat that cause. So the question is why for this talk is dysphagia is defined as difficulty in breathing, difficulty in speaking, difficulty in swallowing. Thank you.
Thank you, Dr. Imtiaz. Our next speaker is Dr. Ziad. He will talk about the baby colic.
Assalamu alaikum. Our topic today is the baby colic or infant colic. First of all, the crying is the normal way baby communicating, seek attention from parents, communicating, expressing their need for food and hunger. If the baby has an illness, if he wet diaper or discomfort, so on. And for all those reasons, the baby normally cries the whole day for 2 to 3 hours, the whole day. This is the normal crying pattern, what we call. But if the baby is crying much more than usual, that means in these characters, if he lasts to cry more than 3 hours a day in more than 3 consecutive days, for at least 3 days per week, or for at least 3 weeks, this is what we are calling colic or infantile colic. This colic is different from the normal colic pattern. The cause is unknown usually. It is not due to illness. It is one of the definitions, crying in a normal baby. It happens in 20 to 30% of babies. Babies, we are talking about the infants. Usually it starts from the age of 2 or 3 weeks, and reaching the peak in 6 weeks, and usually it disappear at the age of 3 months to 4 months maximum. How to know this type of colic? By its symptoms. It is high-pitched cry, the baby is difficulty to comfort, it's red or flushed face, the knee is drawn up to the chest, excessive gases. It's, as we said, it's difficult to comfort, and it worse in afternoon, late afternoon or evening. Next. This type of crying also, if no reason, it's the baby is normally, there is no hunger, there is no wet diaper, there is no illness, and so on. And as we said, it happens in 20 to 30% of babies. It's equal happening in male and female, and disappear by the age of 3 to 4 months. Next. This starts within the first few weeks. It's in the second or third week up to the reaching the peak at the age of 6 weeks and end by the end of the 3 or 4 months. Next. This type of crying is normal. It is temporary, as we said, and it is not it's not causing any impact to the child health. He will grow normally. He will take his food normally, but it is making some noise for the parents. Next. The primary aim or the goal is to soothe the baby as much as possible. Next. There is many things we can try to do with the baby. We can take in the baby for a car ride, or we can take it in his crib and walking. We can using a pacifier. We can taking the baby or swaddling, what we call swaddling, putting it, or you can carrying the baby. Some babies like to be carried on their abdomen facing the parents, and others are like to be spoiled. We can also rubbing the tummy. We can do some exercises. We can giving a warm bath. We can reducing the stimulants like light or other noise or something like that. We can try a lot of things to attempt to soothing the baby, and usually it's not working. Next. Also, it's if you feel yourself is not comfortable, just go to the doctor to just give some instructions for the breastfeeding mothers regarding how to positioning of the baby during feeding, and what is the type of the foods you can avoid or take, and if bottle feeding, you can take an advice from the doctor if she can change the type of milk. But there is no medicine, there is no proof that medicines will work. Medicines, these drops for gases and drops and magharib and dry water. There is no proof that this will work. So just be calm down and take a rest. If your baby is crying a lot, take a rest.
Bring him to Dr. Ziad.
No, don't bring him until you fell down. You can leave him to one of the methods is to leave your baby to cry for 10 to 15 minutes. Leave him to cry. It will not affect his health yet. Then take a rest, take a cup of tea or anything, and you come back to deal with your baby. And it is, as we said, it is temporary. It will end, and don't worry. Unless if you find that it is very different from the usual, from the normal crying, sure, you will seek a medical help. Thank you. Our question here, the normal baby crying per day, is it 30 minutes per day, 30 to 40 minutes? Is it 2 to 3 hours per day, or 5 to 6 hours per day? Thank you.
Thank you, Dr. Ziad. I have one question, please. If you can define the infant period, it starts from which age to which age?
Infant والوالدات يرضعن أولادهن حولين كاملين. Infant period is 2 years.
2 years.
The first 2 years of age is the infancy period.
Even if the baby is not on breastfeeding?
Even if the baby is not breastfeeding.
Thank you. Our last speaker is Dr. Faris, general dentist. He will talk about the oral dentist. Dr. Ganida.
نعم إن شاء الله. بسم الله الرحمن الرحيم. استعنا بالله. Today, it's not a lecture, it's not a quick, it's like hints, not a presentation.
Brilliant.
I prefer